is that Kegels don't fix everything. Some people are very pro Kegel. Some people are like, oh my gosh, especially if you don't relax, don't Kegel. One, I like to call them pelvic floor exercises because it's exercising the pelvic floor. But just like any other muscle in our body, it needs to contract and it needs to relax. And we should be able to do it because it's a voluntary muscle. That being said, it doesn't always fix the issue you're trying to fix. But at least you can rule it out if you can get this muscle doing what it should do, which is contract and relax. So that being said, and I was like, I'm like, well, let's just do it. So I like to have people slow down a little bit and do some body awareness, because the pelvic floor, you can't see it. As amazing as it is, the pelvic floor just isn't that big. It's like a couple centimeters thick. It's just not that huge, even though it does an amazing job of keeping us continent, function in sexual function, postural support. It's amazing.
Hey everybody, and welcome back to another edition of the Physiotutors podcast. Today we have with us Sarah Haag. Sarah is a physiotherapist and co-owner of Entropy Physiotherapy and Wellness in Chicago, and she specializes in both women's and men's health, treating specifically more so on the spine and the pelvis. And that brings us to the topic of today: pelvic floor physiotherapy, pelvic health, and something that I know exists basically in name only. And that's kind of why we wanted to bring Sarah on and talk to Sarah, to educate not only us, but just give a little bit more awareness on a topic that can prove invaluable to patients. So look, Sarah, that's 15-20 seconds as to who you are. Can you maybe take 2 minutes, introduce yourself, give us a little bit more about who you are, what it is you do, and then we'll just dive on into pelvic floor.
Sounds great. We'll see if I can make it to 2 minutes. So I've been a physio for exactly 20 years. And I've been specialized in pelvic health or women's health for about 15 of those. And I fell into it kind of happenstance, which I think some back in the olden days, that's what happened, is a lot of people didn't even know it was an option. So I started to get interested in pelvic health, women's health, did my training through what is now the Academy of Pelvic Physiotherapy, and then also got my Master's of Science in Women's Health. Over the years, I teamed up with Sandy Hilton, who's also a wonderful pelvic physio, who I think is probably better known than me. And and just over the years, we've really tried to educate the world about what pelvic physio is, but more importantly, educate people in the world having pelvic issues that there is help. So I've also gotten into teaching. I'm a faculty member at Rosalind Franklin University in North Chicago, Illinois. And there, one of my primary teaching duties is actually teaching the anatomy of pelvis and perineum to a variety of healthcare professionals. And I love that because I can start dropping in the knowledge of pelvic floor physio to everyone from medical students to physician's assistants to podiatrists. So it's really fun to just let people know that, I guess that's my passion, let people know that there's a pelvis. There's a lot of very important and fun things that happen there. And that while you don't have to know everything about it, you have to know that if those issues are impacting people, that there's help.
Absolutely. And it's two things there that I've really stuck in my mind. One is there's actually a pelvis, because it seems to be this black hole in the anatomy teaching that we had at physio PT school here where I studied. Everything else I can tell you about. And then when it comes to the pelvic region, the musculature and everything around there, it gets a little bit more fuzzy. The window gets a little bit more opaque almost. And then the other thing is, you said sort of pelvic / women's health, and traditionally it is often thought of pelvic floor physiotherapy as more of a women's health issue, but it can also affect men too. And I think a little bit of that adds to some of the awkwardness around some of the conversations that one might have around pelvic health, because especially for men, you're not used to talking about that area. So at least from my knowledge of a few things that the pelvic health can interrupt, let's say, it can cause people to have incontinence of both fecal and urinary. It can cause people to have pain during sex, for men, erectile dysfunction, and these sorts of things. And again, it's something that isn't really addressed too much within your basic education in physiotherapy. So could you maybe take a few minutes and explain to us in a sort of nutshell what it is that you do and what are the kinds of things that you're addressing within pelvic floor physiotherapy? And I know that's a big loaded question, so broad strokes will be absolutely fine for the start.
Okay. So I would say one of the things that we do, and I will say pelvic health, because I would say more than half of my current patients actually identify as male. But then there is, like, we do have the ability to treat like anyone across the spectrum. So regardless of who you are or how you identify, you still have a pelvis. And to be perfectly honest, the anatomy and the function is fairly similar. So especially from an anatomical perspective, I know a lot of times we focus on the external parts that tend to be very different, noticeably different. When we actually get into like the muscles and the nerves, it's basically the same. So I think one of the best things about a good pelvic floor therapist is that we're not shy to ask those questions, and we can ask those questions in hopefully a non-threatening, very comfortable way, asking about the sexual function. And again, trying to work out, is that a priority? I work with a lot of men who are going to have their prostates removed due to cancer. And so, we talk about, this surgery is going to impact bladder function or continence status, but then also sexual function. How important is that to you? And also, how's it going now? Because that's also a topic that can be really hard to discuss, but there's more and more studies on a bunch of different conditions or dysfunctions where if you understand it or you expect it and you have those more realistic expectations, the emotional impact after surgery is less, and the recovery tends to be better. So we ask about that. How's the sexual function going? We ask about the continence, and not just do you leak, but kind of asking, do you rush to the bathroom? Do you almost not make it? How often are you getting up at night? And these are all questions that we might not think about when it comes to incontinence, but those are also things that actually in any setting is really important. If you have someone getting up 7 times a night, well, we're not getting good sleep. We might have some safety concerns. So we can sometimes identify those other issues that might be a safety concern. So we talk a lot about bladder function, but also if it's a bother for people. And then we talk about bowel function. And my favorite answer, when I usually just ask it like that. So can you tell me a little bit about your bowel function? And people will say it's normal. And and a lot of times it's like, check, normal. But pelvic floor physios will know to ask, can you tell me what your normal is? Because some people, it's their normal and it's not a bother for them, which is great. But if you're only having a bowel movement once a week, that's curious. And we might want to ask some follow-up questions. If you're having 7 a day, also, we might want to follow up on that. So having people feel okay to bring up issues maybe they haven't felt comfortable with or had time to do before in other visits. But then also, we kind of know what physiological normal is, what those ranges are, and when maybe there's something that could be improved. So that's actually a lot of my assessments now, and my evaluations are a lot of talking to really get an idea for how things are going with people in education. But then when we get to the physical exam, and I'd say that's what people usually think is so different about pelvic floor physio, is we can actually assess the pelvic floor muscles internally and externally. But I think internal, again, is what most people focus with. And that's pretty amazing. I think pretty much every physio program in the world will teach you to assess or test every muscle in the body. And for some reason, we just cannot get comfortable with the idea of testing that muscle. So we learn how to test like the digiti minimi, but we're too shy to assess the pelvic floor.
Yeah. Everyone gets conservative when it comes to the pelvic floor area. Yeah. So, you've mentioned some things there with incontinence, with rushing to the toilet and almost not making it, or going to the toilet multiple times. Are there any sort of almost red flag questions a physio could ask that might give an indication that, hey, this might be worthwhile referring on to a pelvic floor physio? This might be outside of my remit, my scope of expertise.
Yeah, I think that we should all know how our bladder and bowels are supposed to work. And that people should be able to have sex without pain if they want to.
Ideally. Some
So,
people like that, but that's a different story.
right. And I mean, if you like it, it's not pain.
Yeah.
But so I would say for the rushing to the bathroom, I think especially for females, things like going frequently, leaking when you laugh or cough or run. There's been a lot of it that's been normalized, which I think it can be a challenge to help people get help when they would want it. So I can't tell you how many patients I've had where, it's like, well, I've had 3 babies. Of course I leak. Well, I'm of a certain age. Of course I leak. Or, well, my mom leaked and my grandma leaked, and so I leak. And and so I would say any leaking, I wouldn't say is necessarily a referral. Yes, I would try to get them to talk to a pelvic floor physiotherapist, or ask them if they've actually talked to their physician about it, just to kind of see, make sure there's nothing else going on. But a lot of times these problems have been going on for years, if not decades. So it's probably, odds are it's not an acute issue that would need immediate medical attention. But yeah, I would say that if someone is going to the bathroom more than once an hour, because kind of normal voiding, I'd say normal voiding intervals, like during the day, is like 2 to 5 hours. So if you're going every hour, we can talk more about that later. Like, this is what you would do or what you would ask. But really, if you're going every hour, that's kind of a lot. I mean, maybe you're drinking a lot for some reason, and that would explain it. Maybe it doesn't bother you at all, but I would at least go, do you mind going every hour, or would you be interested? I have a friend you could talk to about maybe seeing why you're going so often. Same with leaking. I already said that, but leaking, like just in general, there's different reasons why people leak. And I would say, my pelvic floor physio friend could help you figure out why that's happening, and then see if you can change it. And really, pain with intercourse, or really sexual dysfunction in general, or pelvic pain that's limiting them in other things. Because like if bowel movements are painful, if sitting is painful and the stuff you're doing isn't working, pelvic floor physio would be a great place for them to go.
Okay. There's an elephant in the room that we haven't spoken about yet. That's post-pregnancy. I want to get to that later, but you mentioned then there are some external techniques that can be used. It's something that we're not taught at a physio school because we're somehow a little bit more conservative about that area. Is there anything that we can do as a general physiotherapist to begin to get an understanding of whether or not, this does definitely need to be passed on? This is pinging up positive. So I think it's definitely a good idea to go the way of the physio, or it might be a case of go to your doctor or what have you.
Yes. So I feel like I have like a 2-prong answer. So one thing is anything that you have been working on. So I'm thinking more like in the pain department that isn't changing. Like as you would expect. So let's say we have like what we think is kind of a proximal hamstring tendinopathy of some sort, but it's not really changing. I think we forget, and I wish I had a model with me, how close, right? So where the hamstrings insert, our pelvic floor comes out to like our ischial tuberosities. It comes out, it goes up, along the inferior pubic rami. So when we're looking at kind of the proximal, well, I guess the hip is proximal, but when we're looking at like the hip and those, and some of those muscles that make the hip move, our pelvic floor is right there. So you can actually, if you're interested, with pants on, actually palpate some of the pelvic floor. It would not be a complete assessment, but you could, when you feel that ischial tuberosity, and then you can just palpate medially, you can feel the pelvic floor. So it's the muscle that's running perpendicular, perpendicular through the body. And you can palpate it and go, You can also have them do a pelvic floor contraction or a Kegel. And just like any other muscle, if it's activating, you should be able to feel it kind of bunch up, and you should feel it let go. I would say practice. Oh, go ahead.
If I can break you there, some people find that difficult to do, to activate the pelvic floor muscles, to do a Kegel exercise. So what kind of cueing could we give for that? Because some people just don't have body awareness. Some people just don't know what they're doing. And for some people, from what I read in researching before bringing you on, is that some people are just constantly tense down there and they don't know how to let go. So then if they're already tensing and they try and tense something else, they're just going to start squeezing elsewhere or squeezing what they think it might be. So how can we guide people on that?
Great question. And actually, I feel like I'd like to think I've gotten better at this over the time of COVID, when I did a lot more telehealth, when I can't palpate people to even confirm if they're doing it correctly or not. Now, I will say that is like an internal pelvic floor exam really gives us great, like you can feel the contraction, you can give them some feedback on strength, like our 0 to 5 scale, but also kind of that relaxation. Like we can really feel like, yes, that did let go, or, ooh, you let it go before you meant to, or you didn't let go at all. So that's where, again, a pelvic floor assessment is really helpful. And I'd also like to interject, as long as I don't forget what I'm supposed to answer a minute ago, so you might have to remind me, but is that Kegels don't fix everything. So some people are very pro Kegel. Some people are like, oh my gosh, especially if you don't relax, don't Kegel. And one, I like to call them pelvic floor exercises because it's exercising the pelvic floor. But just like any other muscle in our body, it needs to contract and it needs to relax. And we should be able to do it because it's a voluntary muscle. That being said, it doesn't always fix the issue you're trying to fix, but at least you can rule it out if you can get this muscle doing what it should do, which is contract and relax. So that being said, and I was like, I'm like, well, let's just do it. So I like to have people slow down a little bit and do some body awareness, because the pelvic floor, you can't see it. And it's not as amazing as it is. The pelvic floor just isn't that big. Like, it's like, I don't know, it's less, let me see here, like, I don't know, a couple centimeters thick. It's just not that huge, even though it does an amazing job of keeping us continent, function in sexual function, postural support. It's amazing, but it's not that big. So some of the cues that we might use to just help someone find when they're completely lost is to squeeze like you don't want to pass gas or you don't want to fart. And we kind of start out just like, can you feel it contract and can you feel it let go? So just starting there, not holding, not doing anything else. And even on telehealth, so through videos, you can see if they get taller or scrunch their face or their shoulders, if they stop breathing. And then we stop and see, can you squeeze and breathe in and breathe out and let go? And just kind of stay super simple. And again, if if you're not into palpating, is you can just ask them, what did you feel? And I don't guide them. I just ask them what they feel, because you should feel something move somewhere. And it should be somewhere down, kind of where you would sit on a bicycle. So like, again, if it's more external hips, probably doing too many glutes. If you feel like you're doing a crunch with your abs, not quite right. And I tell people that you should be able to do it and nobody should know. So if I'm doing it right now, and you shouldn't be able to tell anything's happening, and then I'm letting go. So those are some of the cues I would help them is, again, if they're kind of clueless, we start in the back, squeezing that anal sphincter, because that anal sphincter has tone, and the pelvic floor, the larger muscle inside, is called the levator ani because it elevates the anus. Now, yeah, so that's a good way to kind of find it, but then you can kind of fine tune it, because a lot of the problems people are having tend to be more upfront, so more of a continence issue. And it's really kind of fun because there's been a little bit more, some more studies on getting men to activate the kind of the most optimal part of the pelvic floor. And one of the cues there is to draw in the penis. And so if you think about that, even if you don't have a penis, so when I think about that cue and I think about it, it feels completely different than when I try to squeeze like I don't want to pass gas, but it's still my pelvic floor. It's just kind of optimizing or activating more of the anterior part. Can you feel the difference?
Definitely. Yeah, you can probably tell by my face. I'm glad there's not a video going out with this. But it's definitely a different feeling. Yeah. I have no words to describe it.
That is so fun. And so there are other cues. So sometimes I have done, right? I mean, I don't even know how many pelvic floor exams over the years. And there are times, like you said, people just don't have that body awareness. And I liken it to being kind of like dropped into a foreign country where you don't know what language even people speak. So you're like, parlez-vous français? And they're like, yeah, nope, that's not it. So
Hablo español?
Exactly. So it's like, so you try a cue. Nope, that didn't work. You try another cue, you work together. And, once you establish that there's intact sensation, like, can you feel my finger when I'm touching? Right. So once we've ruled out any sort of neurological deficit, they should be able to contract this muscle. In a neurologically intact adult, we wouldn't say, for some reason, their anterior deltoid's not firing. It must, like, we figure it out, right? We use different cues, different ways to kind of facilitate or increase awareness. But our pelvic floor doesn't just turn off. We just sometimes can't find it, maybe. But you kind of work together to see if they can get it, and then we see if they can reproduce it on their own. So some people, probably, I learned so much from my patients. Probably one of my favorite for a female cue is imagining my labia are church doors. So large double doors closing. So she I was like, whoa, like,
it's definitely visual. Yeah.
Right. And that was because her contraction went from like kind of confused to like a really nice contraction. It's like, what did you just think about? I need to know. And she's like, that was my vision. Because sometimes people will talk about flowers, and some people love that, and other people are like, can we not liken it to a flower, please? So kind of finding that thing that speaks to them. But again, that drawing in the penis is really amazing. And actually in a class, so that's actually a study from Paul Hodges' group. And there was another class we were at, and he was asking other people for ideas of cues, because even though we have some stuff that has been looked at in studies, like, we can make things up. We just need to figure out how to speak to that person in front of us, or how to help them speak to their pelvic floor.
Yeah, absolutely. And I think that's something that we, generally speaking, as physios, have to be pretty good for anyway, whenever we're doing some kind of exercise prescription. because one of the big things we know is if we internalize every little bit of movement and move the knee this way, move the back that way, then everything just falls apart anyhow. So we do have to think in the abstract. So it's quite, yeah, quite nice to know that also when dealing with the pelvic floor, you still have to be that creative as well. So uh, as you've been talking, I've been working on drawing in as well. One thing though is we've been sort of hyper focused, obviously, over the pelvic floor. However, it can be referred pain, or not that the pelvic floor is referred pain, but you can get pain from elsewhere. So lower back, for example, but actually it's the pelvic floor that's impacting it. Can you maybe give us an idea of some of those differential diagnoses and what it is that someone might be able to recognize as to this is the moment to bring in a pelvic floor specialist rather?
I would, first of all, and this may not make me very popular, but I would say, like, even so, if someone comes in with something that I would call pelvic pain, right? So anything like groin, like if we think about like how do we even define pelvic pain? Like it includes the SI joints. Like it includes actually like our hip joints. So what I would say is, especially when it comes to pain, do your best thing. So if we're like, is this being referred from the spine? Check the spine and then do the things you would do for a spine and see, is it changing the things in the pelvis? Same thing, because a lot of times, like I've had some people where they come in with pain with intercourse, and really when we get into it, like they're kind of having a hip issue. And when we address the hip issue, some of the other things, like in the pelvic floor, calm down. And I think that's probably one of the things if I had a wish or I was queen for a day, that it would be that we remember that the pelvic floor, it doesn't act in isolation ever, really, right? It's part of that postural support system. We're using it when we're walking, we use it all day long from the day we're born. So to just remember it's there, and also it's part of the team. So to get back to your question is, again, to like do your screening for the things you're super comfortable on and see if it impacts kind of those pelvic symptoms at all. Give it a go. And then if it's not changing, because it should start to change. I would say in the first 1 to 2 visits, maybe it's not all better, but we should be like, I feel like we're on the right road. We're seeing improvements. But if it's just not even touching it, I'd ask, I'd phone a friend to do that, maybe pelvic floor assessment, and to collaborate, because again, so often I think the pelvis gets like removed from the body, and we think we're going to fix it and then boop, put it back in the body. But if
that's exactly how I've asked the question as well. If you think about it, that's still my framing of it is as almost a separate entity to be fixed apart from it. Yeah.
But
No.
It's really not. And it often, when things start, it also usually doesn't start in isolation either. Right. So, even if we talk, I know we're going to get to it in a bit, but like pregnancy and postpartum, like people think just about the pelvic floor. What about the rest of the changes in the body? Like that's a situation. There's a lot of things that change, how your abdominal muscles change, how they may or may not recover spontaneously. How you may have to work a little more than you thought you did. That's the boat I'm in. Like, oh yeah, I should work on that. Like I'm doing well. And also I'm not back to where I was. No, because I haven't been working on it. So to just kind of remember, we can take a look at it, but anything we find that needs improvement is going to have to be, we can keep it separate and improve. Like we can work on kegels, get those muscles contracting and relaxing and strong and confident, but we still have to put it back in the person who's going to go for a run or have sex or all of these things that involve all of them, including including them as a person, their brain, what they're thinking, all of those things.
So with that said, then what other things are you doing aside from or next to kegels? Because again, for someone who is about as knowledgeable as a bag of rocks on this, it's the first thing that you think of. Do your Kegel squeezes, it's what you've heard on TV. You probably heard it on an episode of House or something like that,
Yeah. So again, so Kegels aren't a terrible place to start. But to me, I kind of liken it to being really strong and then being a good athlete. So with our pelvic floor muscles, with doing Kegels, okay, so we're gonna get them strong, we're gonna contract them, we're gonna relax them, they're gonna be coordinated. We can do them fast, we can do them slow, we can hold them for a long time. We have a pelvic floor that's ready for like a Ninja Warrior competition. But I still leak when I stand up out of a chair, or when I jump, when I play volleyball, or I still leak at that 10th mile of my half marathon. So then we start to look at, so what's happening there in the system, right? So we can go, okay, is the pelvic floor just tired at that 10th mile? Or what else is happening? What's happening with our breathing? What's happening, how are your hips feeling? What else is happening when that happens that we might need to work on? Because all muscles get tired, and we do sometimes hit that physiological limit. That's not really a problem with me. I don't work that hard, but I'll never run so far so fast that I poop my pants. I'm not willing to invest that way, but
might happen. Never say never, right?
True. But yeah, so to then kind of figure out, okay, so we checked your pelvic floor, and this is how, I can't tell you how many times this has happened over the years. Someone comes in with incontinence and their pelvic floor is beautiful. Like it contracts, it relaxes, they know what they're doing. And then, we're looking at things, and like one person I'm thinking of, it was actually not, they thought it was stress incontinence because they were leaking when they got up, but it was more of urge incontinence, meaning they kind of ignored all the signals and had 7 coffees. And so it wasn't so much that their pelvic floor wasn't strong, coordinated, and confident. It's that they're poor, they just stretched those physiological limits with
7 coffees. Yeah.
7 coffees, waiting 6 hours, all of these things where you're like, and your pelvic floor can't get strong enough to never pee again. You're going to have to, but then what it is, the answer for her wasn't Kegels. It was, do we need a louder alarm so that you go to the bathroom? Maybe can we try every 4 hours? If you haven't gone already. Because again, she was having incontinence, but it wasn't just the pelvic floor.
Oh, okay. You mentioned there the difference between stress incontinence and urge incontinence. Are there other different types, and what are the key things that we can recognize there? So the urge incontinence sounded more like you're waiting until the breaking limit. Stress incontinence, at least from what it sounds like, is stress-induced incontinence, so something happening. Are there other types that we might, when we're hearing the story, as a lot of what you said is, and it's also a lot of my learning in physiotherapy as a practicing physiotherapist, is a lot of problems in the body, whatever your patient's having, you can work out pretty much where it is within the story that they're telling you. So are there any other things, at least with regards to continence or incontinence, that might give us an indication as to what way? Stress, urge, etc.
That's such a great question. So the 3 most common types are urge incontinence, stress incontinence, and then mixed incontinence. And I think really understanding the difference between urge and stress helps people go, oh, that's why the Kegels didn't work for me. So urge incontinence tends to be, it's described as it's like a sudden urge. So sometimes, if you just keep waiting, I don't know, that's almost just a behavior. I don't even know if I call that urge incontinence. The urge incontinence is where we're sitting here speaking and we're both fine. And then at the end of our time together, I feel fine. And I look over at the bathroom and all of a sudden I have to go so bad I can't hold it. Or, having kind of, you get these strong sudden urges that are difficult to control. And they can happen for a lot of different reasons. Sometimes we actually train ourselves to have them. But it's not necessarily an overfull bladder, but it's like the muscle. It's almost like our muscle. I think about it like an excited puppy where you're like, do you want to go outside? And like yeah, you like see the toilet or you think about the toilet and all of a sudden your bladder's like, oh, we got to go. Now stress incontinence, again, it's an increase in pressure. I think about it's an increase in pressure on the inside, caused by some activity. So the bladder's not overfull, you're neurologically intact, but like when you run, jump, cough, sneeze, laugh, those things that tend to increase intra-abdominal pressure, and then we leak. And again, it's not just due to pelvic floor weakness, but again, just everything together that should be keeping you continent isn't enough to sustain over that additional pressure that you have. And that's one of them where Kegels or pelvic floor exercises might be more beneficial. And then mixed incontinence, and I think this is where people are like, it kind of worked. The pelvic floor PT, like it was all right. It kind of worked, but I still have these issues. And I think sometimes because the treatment is a little bit different, or the interventions are a little bit different, that you have to make sure you don't give up, and that you kind of identify like, okay, so this is kind of more for these issues and this is more for this issue. Urge incontinence is sometimes really looking like behaviorally. So sometimes you can find, not always, like easily identifiable bladder irritants where the issue is happening after that coffee or after that glass of wine, or, so you can kind of find the things that make it happen. So if they're kind of describing, I'm totally fine until I think about the bathroom. I plan my day or my shopping trips as to where I know there are bathrooms. Or even if you just notice someone during one of your physio sessions, like you needed to wait because they were in the bathroom, and then halfway through your session, they're like, can I go to the bathroom real quick? Those are usually, again, more of those urge incontinence potentially, or just like maybe more of an urgency issue, which is also something to be talked about. The stress incontinence, if they're active when it's happening, and it might be something that, when you think about like jumping on a trampoline or running a marathon, you're like, that's a lot of stress on anybody. But sometimes, depending on the situation, it could be something like going up the stairs, lifting up your baby. I've had some people where it's just, again, like just getting out of a chair or rolling and getting out of bed is enough stress that they leak.
Pretty intense. Jeez.
Sorry, I didn't mean to make it sound intense.
In the sense that it can have some profound effects on someone's day-to-day life, especially if they're having to plan their day around the nearest toilet. That's I imagine for some people that can be quite rough. So from the picture that I'm slowly producing in my head, you've got your Kegel exercises, and then you've got modifications that you might be able to use, adjusting the day a little bit, in terms of, hey, don't wait 6 hours for yourself to burst, go after 4 hours. Are there other things that you might suggest or you might do prescriptively for a patient?
I would say it's usually pretty individualized. But some of the general things that I use are kind of like squats, lunges, balance exercises, actually. Again, not so much, even though our pelvic floors are involved, these aren't meant to be like pelvic floor strengthening exercises, but it's more slightly challenging physical activities that you can kind of slow down and break down and kind of focus on, when do we run into issues? And when I say issues, it could mean actually anything. Do you lose your balance? Do you hold your breath? Do you notice that you leak when you do this one? Because identifying that and then going, okay, so you leaked on that one. What's something you can change? So, can you make sure you're breathing? Can you, is there a point where basically your legs aren't strong enough? And that's kind of the issue, is that your legs aren't doing all the work. So you're kind of bringing it up, and doing things in kind of a funky way that isn't the most efficient, causing you to leak. But I like something like that. And when all else, when I struggle to find something that they're willing to do or able to do, I'll actually have them just work on walking, but walking quietly, or like they don't want to spill, depending on the audience. Sometimes I'll talk about like, just, you have a martini glass and it's full. And you're trying to walk across the room, right? We walk a little differently, right? So like, we're going to walk a little taller. We're going to walk a little bit more mindfully, a little slower, and just kind of slowing everything down and feeling where we lose it a little bit, and working on that, and then speeding it up to like real world. Now you're like a cocktail waitress where you can carry a whole tray full of them without spilling. Again, just trying to kind of integrate everything back together, as opposed to just, more Kegels.
Isolating it. Yeah. This bringing back the full functionality rather than just the one aspect. Like you said, the big, strong person from the gym who may not necessarily be a fantastic athlete, despite the fact that they can bench press a truck.
Exactly. It doesn't make them a good basketball player, a good football player. It just makes them strong, which is great, but it doesn't bring in all that coordination and nuance.
No, functional movement on top of everything else. Yeah. Okay, nice. And then what about with regards to post-pregnancy then? Because like you mentioned, there's a lot of changes that happen in the body. My missus just went through it not too long ago, and yourself as well. You've been through the process.
Mm-hmm.
It's ridiculous. Hats off to you. I am in awe at the changes that you go through, essentially. Should all post-pregnant women go to see a pelvic floor specialist, or is it something that should only be done in certain circumstances, or are there certain determinants that might point you in the direction to say, yeah, okay, I need to go and this person doesn't?
I would say the only, how can I say this? I would say, again, if someone made me queen for a day, every single person who ever gave birth would have access to pelvic floor physio if they wanted it. I will say that some women don't want it. So I think their education is key, going like, okay, so this is what right? A lot of people don't even know what we do. So this is what a pelvic floor physio could assess and take a look at, and offer you assistance with. And then they could get it if they wanted it. But I don't think it should be required of every woman. I think women who have just given birth have done what was required, and they get to have that autonomy of like, I'll deal with it in a minute. But I do think that women need to be educated and understand what options they do have, and have access to that treatment. I think that's a big problem in America for sure, is that it's kind of like, we get like my 6-week checkup was on the phone. Nobody checked anything. And I think, for better or worse, my background for my profession gave me a really good, like, I knew that I could have asked for help if I wanted it. But I also kind of knew what to expect. I knew it was going to be a rough, messy couple of days, couple of weeks, and that I would heal and that I would get better. I think I've met women 5 years postpartum who never knew that, and they never had that confidence. So it's a lot of words to say, yes, every woman should be educated that it's an option and have access to it. That being said, some women never have a day of pelvic floor physio in their lives, and they recover beautifully. and live their lives well. So
What things should someone who's just given birth look out for then, if they are or if they're potentially in need of pelvic floor physio? What sort of things should they be aware of?
I would say immediately postpartum, first of all, give yourself some grace. Stuff is going to be sore. Stuff is going to be leaky. Again, give yourself some space and some time. You are a miracle worker. And this is regardless of if they had a C-section or if they had a vaginal birth. So yes, just recover, give yourself some time. The one thing I would say, which should immediately flag a pelvic physio or a postpartum, sometimes the training is completely separate, is if the woman is having pain that is impacting her ability to take care of herself or her baby. So I did a home visit for a person who basically, it was like pubic symphysis dysfunction. Like she couldn't walk and she lived on the third floor of a walk up. And right. So now you have a baby, you have stairs, so she was a prime candidate for more immediate. I also like to work with women while they're still pregnant. So they know what those kegels are. So you can kind of, yep, I'm doing that right. Yep, I feel it let go. So that they know after they have the baby, again, regardless of how the baby is born, or babies sometimes, right? Is that they can start to work those muscles and understand that it's safe to move those muscles, right? So it's safe to move them, and to see, can I contract it? How does it feel? Can I let it go? How does it feel? So they can start knowing that before they have the baby, and then start it up after the baby is here, and they can identify if there's kind of an issue. So if they're like, yeah, I'm trying, like I know how to do it because I did it before, and I'm having a lot of issues, I'd have them call and see a pelvic physio. And then this is what I would say is, like, after 6 weeks, if you're leaking urine, having difficulty with bowel movements, things like that, then it's usually time where, like, okay, let's do a pelvic floor exam, see what's going on and see what you need to work on. For some reason, someone has an abdominal surgery, they get like 6 to 12 weeks of like lifting restrictions and, like, just make sure you're walking, take care of yourself. Women have a baby and they're like, here's your kid, good luck with that. And that's regardless of how the baby comes out. Again, like, if anyone else had abdominal surgery, they wouldn't say, here's your baby in their carrier and their diaper bag. Good luck.
I'll forget that. Yeah. We got 3 of those.
Right. So I think that, again, giving some time to heal, and again, that grace. I know on TV, it looks like people do it way sooner and way easier. It's different for all of us. But again, if you're leaking urine, we can start to get checked, but 6 weeks isn't that long. So we can check it, let you know you're on the right way. You're on the right road. Give yourself some time. I usually tell women, as far as like they're asking about diastasis, they're asking about all these things. I'm like, give yourself a year. It took you 10 months to get this way, and then you got the baby out. That's a long, slow change. You're going to recover probably quicker than that 10 months, but also almost never are women recovered as fast as they think they should be.
Fair. Yeah, no. Is there then any difference with regards to a vaginal birth or a C-section to what they may or may not experience, or potential complications, shall we say, for the pelvic floor?
One of my colleagues from 15 years ago, she's like, you can kind of tell in the hospital how a baby was born based on how the mom's getting in and out of the bed. if it was a vaginal birth, it's kind of like, I'm not going to sit there. Ugh, I'm trying to avoid that. And then if it was a C-section, like how they get out of the bed, like it's different. As far as, like complications, outside of the actual surgical complications, right? So there's risks involved with any surgery. I would say recovery is a little different. Again, we have sore abs, and the scar that's going to be healing and all of that, as opposed to any stitches or repair of the perineum and the pelvic floor. But that's tissue healing. That should be okay. There hasn't been a lot of evidence that I'm aware of, at least, that shows a C-section would be kind of an easy way out. There are, like at 1 year postpartum, regardless of how the baby was born, similar levels of pain with intercourse, incontinence, and things like that. So, I mean, it makes you think if maybe the really challenging part isn't so much the getting the baby out, but really the changes that happen, again, over the course of those 10 months. Having vaginal birth does, especially multiple vaginal birth, does increase the likelihood of pelvic organ prolapse more than multiple C-sections. But other issues like incontinence and pain with intercourse, sexual dysfunction are actually quite similar.
What are some of the other changes then that would occur for us to be aware of during or post-pregnancy that may be an indication for pelvic floor physiotherapy intervention?
Again, I think it's mostly based on symptoms. So, if a woman is having urinary incontinence during pregnancy, I think, again, it's really easy to go, well, she's pregnant. I think, hold on, let's make sure everything's working as well as it can. I mean, again, I'm sure your partner could tell you that there gets to a point where it's just, you're at that critical mass where there isn't room for a bladder anymore.
Okay.
So it needs to be emptied regularly. But, I never want to just go, it's because you're pregnant, it'll get better later. Let's see if we can change it now. So incontinence is a huge one. Pain is another huge one. That's pain with intercourse or any other pain in that general lumbopelvic region, is get that checked. One of the things that, literally brings a tear to my eye is when people are like, you just need to get through the pregnancy, and after you have the baby, you'll be fine.
Ooh.
Well, not if I'm not able to be active between now and then. Not if I'm in pain every single day. And then I always think, like, what part of getting a baby out do you think is going to make me feel better?
Yeah.
How is that going to fix my pain? But I have had patients where once they have the baby, everything seems to feel better. But I've also had a lot of patients who are still in pain years later because, it's because you're pregnant, and then it's because you had a baby, and it's because you're older that you just have to live with these things. And I think it's not fair. And I think, to be honest, if it wasn't a pregnant person or a person who'd been pregnant previously, I don't think that'd be acceptable healthcare.
Oh, and it's just listening to that, it's so easy to fob it off. It's so easy to say, yeah, but you're pregnant. Yeah, but you just gave birth. And that final one, yeah, but you're just getting older. It's so easy for someone to fall down that slope instead of, and I don't think, I hope it's not just that they weren't taken seriously. I hope it was whoever the healthcare provider is that says that is taking them seriously, but does genuinely think that it's just the age factor or what have you. But it's so easy to slip down that curve. If you think, you've got a 40-week pregnancy, and then most people are going to say, wait 2 months and you'll be all right. Then they wait the 2 months, and no one's got the calendar out and marking the calendar for their follow-up. That follow-up appointment might be 6 months down the line. So you're a year and a half further. Probably a little later, because after you have kids, the schedule's not yours, it's the schedule for the kids. it's so easy to fall down that. Yeah, it makes me wonder, why are we not fed more information about this, or at least given an indication as this is something that we should be aware of during our basic study, because it's something that we will come across for sure, and to at least have the indication of passing them on to someone who is specialized in this region, rather than the classic fobbing off of, oh yeah, pregnant, oh yeah, baby, oh yeah, you're getting old. It's a little bit disconcerting, actually, now when you put it like that.
Well, I think the good news, I think there's hope. So there are more people talking about this now. In fact, a colleague of mine at Rosalind Franklin, Natalie Turrentine, her student research projects, we have our students in the PT program do research projects that go over 2 years, and she's really been looking at programs. So at least here in the United States, like, why, like, is this in there and why not? And looking at clinicians and like, because there is professional, like post-professional education, you can find this if you want it. But again, I think there's just still so, I think it's kind of almost more social. And then it's just supported by, physio programs are really full of information. We don't have time. We don't have the space to add this. And if professors don't think it's important, if healthcare practitioners, it wasn't part of their training, and if people don't know that there's help, it just keeps on sliding away until it's you or someone you love. Then you're like, hold on,
Yeah. Yeah.
this needs to be addressed. But I think what maybe frustrates me a little bit is I don't think it's that hard. I don't think it's that hard when we're learning normal physiology to be like, and this would be different. Like how would pregnancy, how would like an 8-pound fetus impact this? We talk all the time about obesity being a problem. Now, pregnancy is not obesity, but it's additional weight. And I think we also don't let that challenge our biases and our preconceptions, because there are pregnant women running marathons. I was not that pregnant woman, but there are women who do it. There are pregnant women who compete in high level athletics, depending on the sport. There's pregnant women working 12-hour shifts at a hotel changing beds. Like, pregnant women aren't weak. But I think sometimes when, I've had it, when I worked in another facility, like if someone came in 6 weeks pregnant with ankle pain, get her to women's health. And it's like, hold on. Yes, there are some physiological changes that may be happening at 6 weeks. You know how to treat an ankle. To kind of have that, have it be part of, so this is a person who happens to be pregnant. Is this issue part of the pregnancy where I need to either refer her back to her doctor, or do I need a specialist, or as a competent physio, can I start to address this and think about what this might mean in another 6 months? If that 6 months now she's, 36 weeks pregnant, or has a 2-month-old, right? So like, what does that look like from a functional aspect? So again, I think like the specialty of pelvic physio, of women's health physio is amazing, but I think in the Venn diagram of physio practice, it's really, it's not just all R's, and it's not a secret. Like all of if you treat people, one, they all have a pelvis and they should be using them daily. But number two, like it's, people know things. They just have to know that they can change and they can get better, and that there is help if they don't know what to do.
I think that's a beautiful place for us to wrap up as well. No, that's a nice way to put it, with the Venn diagram of physiotherapy. Have you got any suggestions for people if they want to find out more about this, or where can they find you?
So they can find me on Twitter at Sarah Haag PT. That's probably the most fun place to meet up. Meeting up in my inbox for emails is a little bit of a disaster. I do my best, but I'm slow. Or there is a Physiotutors webinar that I forget the exact title of it, but it's basically pelvic health for non-pelvic health physios. So it's not scary, it's not internal, but it's kind of a good general knowledge dump on bowel bladder and sexual function, and how it's not scary and mysterious, but really quite normal, and should be a part of, should be like a highlight of the day, not the worst part of our day.
Nice way to put it. All right, lovely. Well, look, Sarah, thank you very much for your time today. Really appreciate you being able to talk to us. And yeah, I hope you enjoy the rest of your day.
Yeah, absolutely. Thank you for having me. It's been too long. This usually happens at conferences and things like that. But with COVID, I've definitely missed chatting about it. So thank you for having me.
Well, ladies and gents, thanks again for listening in, and we'll catch you next time. As always, wherever you're listening to this, we appreciate your time. And if you have any comments or suggestions, feel free to get in contact and let us know. Until next time, peace.